Hi viewers, my name is Dr. Mayur and today I am going to present another case of IVF, and in today's video we'll be showing how easy and straightforward IVF treatment is. Many people are always stressed, and most people say IVF is a very big and painful and a complicated process. So I'll just be simplifying it and showing you the entire process, right from how we have made the patient's eggs, what injections we have used, how many days worth of injections the patient has received, and at the end of it we will be showing you the egg pickup procedure live on your screen. Okay, so this is a patient who is a 35-year-old woman who has come to me with an AMH value of 2.5. Usually 3 and above, 4 and above AMH we tend to get very good quality oocytes or eggs. Below that we start struggling, but 2.5 is quite a good value, and we do expect that the woman is going to produce good quality eggs. Husband count, there is no doubt, husband count and sperm parameters were very good in this case. Along with that, patient is an ANA positive woman who has previous history of I think one pregnancy loss. So we have started the patient. Patient gets her natural menses, following which we are beginning the cycle. In today's case, we have you can check it out over here. We have used an RFSH stimulation, and along with that we have used HMG and letrozole, 2 tablets of 2.5 mg. So over here on day 2 we are beginning with her check ultrasound, where we see the number of follicles, resting follicles in the right and left ovary, seeing how much is the endometrial basal thickness when she is shedding her endometrial lining. So RFSH 300 is the chosen dose that we have in this particular case, and HMG is another injection that we are using in this case with a dose of 150, plus I have given letrozole, which is an oral tablet of 2.5 mg into 2 tablets, that is letrozole 5 mg. So every day we are going to give this injection for first, second, third, fourth, fifth day, and sixth day of stimulation, that is over here, we are going to reassess by ultrasound. So now let me show you what RFSH looks like. So here is the vial which I have used in this particular case. I'll unbox this vial and show you. Okay, so this is the vial that I have unboxed right before your eyes. Okay, so here you can see that it is an unopened vial. Roughly this vial costs 25,000 rupees. Okay, I can show you right here the cost, you can see. So this vial costs 25,000 rupees for 1,200 international units, and you can see that it's already a pre-manufactured liquid formulation. Along with this, it is given in a syringe. Along with this we get some syringes which are pre-calibrated by the company, meaning if I draw till here, we can see over here how much IUs, international units I am picking up from the vial. Number this day. Okay, so let us say in this particular case 300 is my dose, so I have to go up till this line. I have to take RFSH up to this line and just inject the patient subcutaneously over here like a standard insulin syringe. So I have shown you how we go ahead with your RFSH 300. Let us see HMG 150. So here I am showing you another type of drug. This is called HMG or menotropin. Over here I'll unbox this also and show you. So here we open this up, and inside we find a vial, and as you can see it is a liquid formulation which is pre-manufactured by the company. The cost of this drug is 8,900 rupees for 600 IU. Correct this way? Okay, so again this comes with another similar syringe from that particular company. So you just have to find out how many international units you require, draw it in your syringe and give the patient subcutaneously like a standard insulin syringe. So I have now simplified and shown you how easy it is to give this particular injection to the patient. All these injections can be pre-filled by the nurse or someone or a pharmacist and dispensed to the patient, so that the patient herself knows that on this date you are supposed to inject one of this and one of this, and tablet the patient can have by mouth. Now since this is done for these many days, again now the patient comes for a check ultrasound. The check ultrasound we are doing transvaginally, which is a mandatory step in every case of fertility treatment, may it be IVF or IUI or whatever. So this particular patient comes on day 7 of her cycle, which was on 25th of the month, and we found out that majority of the follicles on the right side were 11 mm in size, that's in diameter, and in the left side it was roughly 12, 14 is the size, and there are other sizes also that we have not yet mentioned over here. We can see that the endometrial lining is 6.1 millimeter and vascularity of the endometrium is quite good. Following this, we have gone ahead with the same treatment. Over here there is something called a premature LH surge that happens mostly in cases of IVF and superovulated cycles of IUI. Now what is this LH surge? A normal human body, a lady's normal human body is designed to make 1 or 2 follicles per month. Whenever this lady produces more than that 1 follicle per month, there is a chance that there is a hormonal phenomena that takes place in her body which causes premature rise of a hormone called LH. So I'm just simplifying everything over here. This LH surge, when it happens, it causes the cycle to go non-fertile, as in it decreases the fertility of the cycle. It can also lead to premature ovulation, as in when the follicle is not fully mature, it can undergo ovulation, it can undergo luteinization. Both these things are not very good and these are against the fertility part of the IVF cycle. So over here, what we end up doing is we use something called cetrorelix. It is another injection. Again, this injection comes as a pre-filled form or as a lyophilized, that is a powder and water combination. Here, as you can see, we have chosen to give the patient cetro powder, that's a lyophilized formulation, and 2:30, meaning this is injected at 2:30 p.m. in this particular patient. Why is the time mentioned over here? It is very important that once cetrorelix injection is started, it has to be taken every day at the same particular time. You cannot mess up the time, or in case you mess up the time, you are messing up the fertility and the prognosis of the particular case. So this is the way how our fertility unit is working. We mentioned the time over here. This has been done by the pharmacist only. So RFSH that day also 300 was given. HMG 150 plus 150, that is 300 units of HMG was given. Oh, I'm sorry. RFSH we brought it down that day. Okay, we brought it down that day to roughly around 112 international units. So RFSH, I'm sorry, 112 international units. Along with that, HMG 150 plus 150, that is 300. This was the dose that was chosen. How do we arrive at the dose? Well, that is the decision of the fertility specialist. That is what we are trained for, to understand which dose of which drug is best in that particular case. So this checkup which was done on the 7th day was very useful and very important. Following this is the treatment that we have gone to on 25th, and this has been continued for a further few days. Definitely over here there are other ultrasounds that were performed which I have not mentioned, and roughly somewhere close to the 12th day of the cycle, we find that the patient's both side ovaries have mature follicles. This is the time when we assess the ovary using transvaginal ultrasound. normally a rough dictum for you to understand is any 3 dominant follicles crossing 18 to 18.5 millimeters in largest diameter, we say that it is a mature case. When that happens, that is the time when we go ahead with triggering the patient. Now, what is this thing called a trigger? Trigger is basically that drug that causes ovulation in the particular patient. So roughly most triggers, let us say we give a trigger to a patient at 7 a.m. in the morning, then this patient roughly starts ovulating at 7 p.m. the next day, that is after 36 to 42 hours roughly. So what happens is most IVF treatments, that is most egg retrievals, are timed at the 35th or the 36th hour. It is said that you can do IVF anytime after the 34th hour of the trigger. So what is trigger? Trigger causes the ovulation and the final maturation of the eggs. This final maturation is important for IVF, and ovulation is something that is bad for IVF. So we have to time the egg retrieval only after complete maturation of that oocyte, that is roughly taking place around 34 to 35 hours after giving the trigger. However, if we, let us say, delay the egg pickup to 36 hours, the 37th hour, what happens is the chance of ovulation in the dominant follicle increases, and the follicles may rupture and ovulate and disappear into the peritoneal cavity and will not participate in the IVF procedure. So we have to find a good balance between the final maturation of the oocyte and the ovulation. So the sweet spot is somewhere between the 34th and the 36th hour. Definitely the IVF specialist knows which case what is the right time to use, whether it's the 34th hour, 35th or the 36th hour. There are cases where we sometimes delay it even up to the 37th hour, but those are exceptional cases. But in usual cases, the IVF, the egg retrieval, is planned at the 35th hour as roughly a gold standard in most cases. So in this particular case, you can see lupride, that is lupride acetate is what we have used, and we are planning to do a 36th hour egg retrieval. Why so? It is left to me as the decision, and I feel that in this particular case 36th hour egg retrieval was the best thing that we could do. Now the next thing which you will be seeing on the video is the procedure of egg retrieval. Now let me first tell you something a little about egg retrieval process. In egg retrieval we give either general anesthesia, that is with IV propofol, maybe sevoflurane may or may not be used depending on the anesthesiologist, or we do it under spinal anesthesia. Once this thing is done, the patient is anesthetized. The actual process is very short, around maximum of 10 to 15 minutes. You will be seeing the live footage of this procedure next. Do stay tuned, and I will be explaining every step that is being done in that procedure. Thank you. Hi everyone, here you are seeing the live oocyte retrieval process. On the screen, what you are seeing is the picture on the ultrasound of the right ovary of the patient. First we do a small Doppler examination just to see where the blood vessels are there. It is not a very good idea to poke the blood vessels whenever possible. Try to decrease the bleeding. Also, this gives us a good idea of how to penetrate the ovary. Here on the screen, that silverish needle that you see, it is the needle for egg pickup that I have thrust inside. Okay, you can see every follicle is that black color ball that you are seeing, and this needle is connected to a suction pump that very gently sucks out the contents of the follicle into the test tube which is lying behind me. In the background you can hear my staff who are continuously telling me the drop rate of the content. Okay, we are doing this procedure in Goa, and here the local language is Konkani, and continuously you will be hearing my extremely helpful staff telling me the drop rate. We have call signs which are developed in our OT. Yeta yeta meaning good flow coming very briskly and sharply, and if it is slowing down they either say drop wise it is coming or drop by drop it is coming. And once the test tube is filled, we say stop. Stop meaning they are changing the test tube. However, I do not do anything apart from reassessing the case at that very moment when they are changing the tubes. Here you see I have a habit of going for the furthest follicles first. The reason for this is the imaging of the furthest follicles will be really well if they are penetrated early. If they are penetrated later on, what happens is because of the clotting and the poor sonographic pickup of the at the later stages, like if you start doing the closer follicles first, that follicles get refilled with blood, and once that happens the image quality of the further follicles go down. So I like to do the peripheral, the furthest follicles first. You can see as the case goes by, it is done in real time, as in the video has not been fast forwarded or anything. You can see that by now 50% of the right ovarian follicles have been retrieved. At the end of every follicle, you can see that the needle twists a bit. This is called curating of the follicle. This helps us in getting the oocyte which may be stuck to the wall. Okay, so some of the rules while doing this is we try our best to make sure that the needle which goes in follows the guidelines that you are seeing. You can see those dots which are there on the screen. The needle should ideally follow those dots. If the needle is going to the right or left of that dot, that is not a very good and pleasant thing to be operating under. You can see now that almost the entire ovary is done, and you can see this is a fairly marginally mobile ovary, and we have that the furthest follicle right there, and just after the follicle are the great vessels, the great iliac vessels. So we try our best not to be very heroic in these procedures and go very close to those vessels. So that is one of the dictums which I would like to stress upon, in especially those people who are learning IVF or have done very few cases. It is a very good thing not to play heroic. Here now you are seeing the second ovary. This is the left side ovary. Again we begin with a small Doppler study, and since we know where to go in, we penetrate the ovary. Again you see me going through and through the first follicle to the next follicle. Always we have a wingman concept in our hospital, which means along with me I always have my radiologist, whose hand you can see very often. The help that the radiologist does is that she helps me fine tune the machine just by voice command. She makes sure that the image quality is as brisk as I want, and at the same time being my wingman, he has to keep an eye on the other things like the great vessels which are peripheral to the needle. This helps in improving the safety of the procedure. That's what I feel, and I strongly believe IVF is a procedure of luxury, and there should be absolutely immense safety when you are going ahead and doing that. If you feel that the peripheral follicles are a little bit scary to approach, it's always better to leave them and go ahead with whatever you have, rather than causing a puncture in the great vessels and causing a hazard. Here you see almost 50% of the ovary is done. Another thing which I would like to show you is right at this stage, you can see the moment we try to thrust the needle inside, the ovary moves. Sometimes you may find such ovaries which are more mobile and not very cooperative. That is the time when you should withdraw the needle and poke at a different site, and sometimes you may find that the peripheral follicles come close by as the ovary keeps getting aspirated, and you can have a different path of approach to those peripheral follicles. Here you are seeing that the peripheral most follicle, the moment the needle tries to go close to it, the follicle goes away, or the needle rotates the ovary. All these things sometimes do make the ovary a little bit less cooperative. So we should try our best to get as many follicles as possible. Here you are seeing the last 2 or 3 follicles being aspirated from the ovary. This is the left ovary, and just now we are going to finish the case. We also try to lessen the number of pricks that the ovary gets. So if you see very well, both the ovaries have got hardly one prick in the main surface of the ovary, and however we have pivoted the ovary in such a way that we have managed to get all the follicles through that single prick. This patient at the end of the procedure will wake up very soon. This case is done under general anesthesia. She'll wake up within 5 minutes of the case, and we will be observing the patient for the next few hours, 1 or 2 hours, and patient will be going home. So I hope you enjoyed the video. At the end of this procedure, we were able to get 8 eggs.